are very eager to listen to Dr. Ayman Elsamadony for also an ectopic kidney, isolated infected leaking common iliac artery aneurysm associated with ipsilateral ectopic kidney.
Bismillah ar-Rahman ar-Rahim. We're forward and we're backwards. Next. Okay. Thank you very much, and it's a hard act to follow. Dr. Magda has presented a very nice case and very challenging proposal, actually. My case is much simpler than that. He's an 81-year-old male. He presented to the ER with a 2 weeks history of shaking chills, fever up to 40.5, and right iliac fossa pain and pulsating mass. He is diabetic, hypertensive with rheumatoid arthritis and chronic calcitis with mild urea impairment. He presented with severe anemia, 7.1 with leukocytosis and actually sepsis. The pelvic ultrasound shows an aneurysm of the right iliac artery. So because of the urea impairment, we've done an MRI which showed that almost a flush right common iliac artery aneurysm with, as you can appreciate, with this pointer, and you can appreciate this vessel, which is the right kidney is an ectopic, with the last lumbar artery is replacing the renal artery. So we are in dilemma what to do, and let us get the patient to the ICU. And you can appreciate, I'm sorry, you can appreciate as well the amount of abscess present here in the substance of the iliopsoas muscle, all eaten up by the abscess surrounding the perivascular tissues. So we decided to admit the patient to the ICU, hemodynamic support and microbial support. However, shortly, only a few hours after admission, he developed a hypovolemic shock with failure of fluid resuscitation, so we pushed him urgent to surgery. We've done midline extraordinary incision, right medial vessel rotation, medial mobilization of the ectopic right kidney with vascular control, aortic, and 2 iliacs, excision of all aneurysmal sac, debridement of all underlying psoas abscess, and we reconstruct by fem-fem crossover graft. And that is the MRA after we finish our procedure, and you can see that we maintain the blood flow to the ectopic kidney. However, the patient course was not that easy. He had a stormy postoperative course with grade 2 other respiratory distress syndrome, hepatic impairment, renal impairment, head syndrome even occurred, cardiac depression, and wound infection with partial days of the abdominal wound, and right proximal iliofemoral DVT. However, thanks to the ICU guys, the patient did well afterwards. The antimicrobial regimen, the blood and pus culture showed Salmonella enteritidis, and antimicrobial regimen was given. He was charged with 3 weeks in the ICU stay. On discharge, his only incision hernia with mild right lower limb edema. Etiological classification of any aneurysmal infected aneurysm is a mycotic aneurysm where the origin is the heart, microbial arthritis where the infected aneurysm coming bacteremia coming from other source or the septic focus on the body, or infection occurring pre-existing aneurysm, or a post-traumatic pseudo-aneurysm. However, regarding microbial arthritis, atherosclerosis is a predisposed bacterial arthritis. Disease the enema allows the bacteria invasion of the subinter plane, forming a microabscesses, wall expansion following usually saccular form, not fusiform. Salmonella we used to prevail prior to 1965, but later on it comes shifted to staph species. Any septic foci could be the Colbright lesion. The special predilection towards the aorta 3:1, however, isolated iliac aneurysm represents only 0.03 at the autopsy and 0.6% of all aortoiliac aneurysm. That's the management. The most sure thing about the management is the policies. You have to have your antimicrobial therapy and support for at least 6 weeks after the completion of the procedure, and the debridement and vascular reconstruction, which will give some space to talk about. I'm sorry. No success is expected unless less than wide debridement of all vascular and perivascular tissues. Do not keep the sac in. That's very important. Vascular reconstruction either in situ, that may be okay in perivascular aorta, The grafts could be cryopreserved homografts, and had one case yesterday presented a bovine graft, or superficial femoral vein, or antibiotic impregnated Dacron grafts. However, it has a risk of recurrence and pseudo-anastomotic aneurysms. The extra-anatomical reconstruction offer less major reconstruction, but more applicable in infrarenal aorta and iliac aneurysms. Durability is always in question, and in event of further bacteremia, fear of anastomotic aneurysm is not negligible. The endovascular, till the moment, the endograft is still controversial. The failure of dealing with the infected tissues is a major setback for these modalities. However, it might help you temporize the patient over a critical period of time, like for presenting with a leaking. Some authors tried endovascular exclusion with immediate excellent results, yet durability to be tested. Still hold a high mortality, any infected aortoiliac aneurysm, 50-70%, maybe because of the diagnostic delay or hemodynamic infective instability, high magnitude of surgery, and associated comorbidities. It differs according to the site. The infrarenal aorta around 10% mortality, or 47 to 52 in perivascular area. The organism usually salmonella, but salmonella do better as mortality figures than the staph. Any unknown febrile illness for more than 2 weeks, you have to suspect there is something wrong. No justification for antibiotic without surgery. Endovascular management is still controversial, but might tie the patient over a critical period. Choice either in situ or extra-anatomical is still controversial. Antibiotic regimen should start before the surgery in elective cases and continue for 6 weeks in IVV form and at least from 3 to 6 months in oral form. Thank you very much.